to be recorded for quality assurance purposes and also for record keeping. And also, please mute yourself when you are not speaking. And you can use the chat function as well as the raise your hand functions that are at the bottom of your screen if you're using a laptop, or at the options if you're using your phone. Also, is there any other thing else? No. So when you're not talking, kindly mute yourself. So as usual, to comments, we have about 9 people on the call. If you just go around the room and do very brief introductions. Our agenda for today is quite simple. We're going to have, after the introductions, we'll have the updates, Africa CDC updates from Chika, epidemiological updates from Chika, and then we'll have the countries represented give us updates on the activities that they're doing in the areas of IPC, surveillance, and lab, and maybe case management and any other updates that is noteworthy. And then that will be it for today. So introductions, I can see Dr. Owen Musopole. He has written that it's from Malawi. Doctor, so if you just tell us your name, what you do, and the country you're coming from. Dr. Owen.
Thank you so much, and good afternoon, everyone. I'm Owen Musopole, a Deputy Director in the Ministry of Health, Malawi. I'm responsible for quality improvement and infection prevention. Thank you.
Thank you so much, Dr. Owen. Kotso.
Yes,
Yes.
I don't know. Can you hear me?
Yes, we can hear you, Kotso.
All right. Thank you so much. This is Kotso, IHRNFP Lesotho. Unfortunately, I'm in a meeting, so I'll not be fully with you, but in the beginning, I will be with you. Thank you.
Okay, and you can also use the chat function to maybe ask your questions or drop your comments. We have Akona.
Hi, everyone. Akona Changela from Africa CDC.
Thank you very much, Akona. Watipaso. Watipaso, could you kindly introduce yourself?
Hello, everyone. Sorry, I am Watipaso from Malawi, Public Health Institute of Malawi. Thank you.
Thank you very much, Watipaso. Annie Mwale. Annie, could you introduce yourself, please? Okay, so we can move to Tendai Chipendo. Tendai, could you introduce yourself? Okay.
Good afternoon. I'm Tendai Chipendo, Africa CDC volunteer in Zimbabwe.
Okay. Thank you so much.
With me is Takuzwa Marembo.
Okay, another volunteer?
Yes, good afternoon, everyone. This is Takuzwa Marembo, and we are using Tendai's laptop together because we're working together. I'm a volunteer again from Zimbabwe.
Great, thank you very much. Annie, can we come back to you? Oh, no. Okay, there is Berekai Bernard. Bernard, could you introduce yourself?
Thank you very much, Barreche Bernard, Africa CDC, HQ, the focal point, EBS.
Sorry? Okay, Africa CDC, HQ, okay, EBS, okay, oh, great. Then we have Ukanedo Colette.
Hi, everyone, this is Chika. I work with Africa CDC as an EPID analyst.
Okay. Yaya Kande, thank you, Chika. Yaya, could you introduce yourself?
Yes, good afternoon, colleagues. I am Yaya Kande, Public Health Fellow with the Southern Africa RCC. Thank you.
All right. So Annie is still not with us yet, but I think Annie is from Zimbabwe. If
No, Annie is
sorry,
from
Malawi. Yes. Annie is from Malawi. Yes, one of our volunteers
Yes.
in Malawi. Thank you very much. So we have just 3 countries with us today. I'm hoping our host country, Zambia, will join us along the line. They haven't said they're joining us shortly, but we'll proceed. My name is Ezine. I'm a public health officer with the Southern Africa RCC, and here with me is one of my colleagues. Could you introduce yourself?
Okay, my name is Humphrey Chituri, I'm the Africa CDC, Southern RCC.
Okay, thank you so much, Humphrey. So we'll just move on to the next thing, which is the epidemiological updates from Africa CDC, which Chika will take us through. Chika, could you share your screen? You can take it over from here.
Okay, thank you, Ezine. Let me share my screen. Liz, are you able to see my screen?
Yes, I can see your screen. I hope everyone else can.
Okay. All right, good afternoon once again. I will take you through the global epidemiological situation as of 29th July 2020. So this slide shows the global epidemiological situation of COVID-19 update as of 10 p.m. Central European Time, 28th July 2020. On the left shows the world map of affected countries, and the chart on the top right shows you the distribution of new cases this week by 6 geographic regions. Each color represents the region on the legend. The green region, which is Paho, is reporting majority of the cases, while Africa is the dark blue bar on the chart, which accounts for 5% of the global cases. And majority of these cases are being reported from the Americas and European region. So globally, beneath the chart, this figure shows you the distribution of COVID-19 cumulative cases, deaths, and the number of affected countries and territories. So overall, the world has recorded over 16.3 million confirmed cases of COVID-19, of which over 645,000 have died, resulting in a CFR of 4% from over 215 countries and territories affected by the pandemic. So this slide illustrates the epidemiological situation of COVID-19 in Africa as of 29th July, 9 a.m. East African time. So the vertical axis is the number of cases and the horizontal axis are the dates. The red lines on the chart represent the 7-day moving average, indicating a continuous increase of 15% compared to last week. With respect to the 5 regions, the Southern African region in gray represents the region with most cases, and overall more than 870,000 cases, of which more than 18,000 have died, resulting in a 2.1 case fatality rate reported from 55 member states. Of these total confirmed cases, the good news is that over half of these cases have recovered, which is about 60.1%. So the Southern region has the highest percentage increase, which accounts for 19%. This table shows the cases, deaths, and recoveries in Africa, as well as across the regions. Over 12,000 new cases were reported from yesterday, with over half of this being reported from the Southern region. And the Northern region is still reporting the highest case fatality rate, followed by the Eastern region. So this is the map of Africa showing categories of member states reporting COVID-19 cases. 36 countries are reporting over 5,000 cases, 10 countries over 10,000 cases, 7 countries reporting within 5,000 to 10,000, and only one country, which is South Africa, has reported over 100,000 cases. This is a snapshot of top 5 countries reporting the most cases in Africa. They are South Africa, Egypt, Nigeria, Ghana, and Algeria. South Africa is still reporting the highest number of cases with a proportion of 52.8%. Together, they account for 75.2% of the cases reported in Africa. Okay, so this is a snapshot of top 5 countries reporting the most cases in Africa. Sorry about that. This graph illustrates the cumulative testing in all African Union member states. Over 8.3 million tests have been conducted across the continent, and then 9.5 case ratio. Then the overall positivity rate has gone up to 10.5%. So this shows the progression of COVID-19 tests per case ratio in 55 African Union member states. 3 countries has over 100 tests per case ratio, 10 countries within 31 to 100 tests per case ratio, and 15 countries within 10 to 30 tests per case ratio, and 27 countries below 10 tests per case ratio. So in terms of the rate of tests per million population in member states, the minimum is 2.8 and the maximum is 596.8. Finally, this last slide shows the COVID-19 cases amongst healthcare workers in Africa region. Based on the available data, healthcare workers in the southern and western regions are the most affected, followed by the central and eastern. No data for the northern, from the northern region. So 48 countries are reporting cases of healthcare workers, and total proportion of affected cases is 1.7. Thank you. Over to you, Izini.
Thank you very much, Chika, for the updates. Any question from anybody? We've seen Howard Nyinka from Zimbabwe join us. Welcome, Howard. So any question on the updates from anybody? Questions, comments? From anyone on the updates? Because Southern African region has really seen, I mean, consistently for the past 2 weeks, we have the slide, that slide on the regions on the percentage increase, we have been the highest each week with the number of cases. You could go up, I think it's around the 3rd or 4th slide. Keep going, up, 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 up. The 3rd one. Yeah, this one and also this one. Shows the Southern Africa, the 70-day moving average. Southern Africa, last week also where we had the highest percentage increase, and also this week we have the highest percentage increase. And unfortunately, we don't have South Africa today. Not South Africa, but to have South Africa on board. That would have been very nice. But that's something I think we should, I don't know, comment or say something about if your country is one of the that has seen a significant increase. There are 2 people who have joined us. Yeah, there's Dr. Paul Zulu from ZMPHI. Could you just introduce yourself?
Good afternoon. I'm Dr. Paul Zulu, an infectious diseases specialist at the Zambia National Public Health Institute and also the country incident manager for COVID-19.
Thank you very much, beautiful. Now we have representation from Zambia. And then we have Sepang Lekhela. I'm sorry if that's not the proper way. Could you kindly introduce yourself and tell us the country you're coming from?
Thank you. Good afternoon. I'm Sepang Lekhela from Lesotho, Ministry of Health, Lesotho. Thank you.
Thank you very much, Sepang. So we have two people. And then there is Anne, who has also joined us. Anne, could you just introduce yourself?
Good afternoon, everyone. I'm Anne Williams, Procurement and Logistics Officer, Southern Africa RCC.
Thank you, Anne. So if we don't have any comments on this, but I feel that's something worth mentioning. If we don't have any comments on
Hello.
implement.
Hi.
Yeah.
Can I make a quick question?
Yes, that's why we present for the questions.
Yes, thank you so much. I see an increased number of health workers getting infected.
Okay.
And indeed, I see it also in my country, Malawi. I just want to learn from your experience. How are the facilities coping up as healthcare workers are getting infected and there's a reduced number of healthcare workers available to do the job? Is there anything that we can learn what others are doing in order to cope up with the as the healthcare workers are going in isolation, in quarantine? What's the experience with other countries? Thank you.
Thank you very much. So I think this is a cue to move into the country presentations. So we can start with Zambia, our host country, Dr. Paul Zulu, who is the incident manager. This is what we just want is for you to give us, we already have sort of like the numbers, but you can give us a overview of how you are coping with the outbreak in your country. And like Dr. Owen has mentioned, if you can also share your experience with healthcare worker infections and other activities you're doing in the area of IPC, surveillance, and anything else worth sharing that we all can learn from what you're doing differently that has helped you. So over to you, Dr. Paul Zulu.
Okay, thank you very much. Zambia as a country to date has recorded 5,249 cases. That's the cumulative total. Our total recoveries is at 3,285. We have a total of 146 deaths from the time the outbreak started. And currently we have about over 1,800 cases that are active in the facilities. Our cases, mostly now that we've moved to a community or home-based model, has reduced the number of patients we have. So of this number of patients that we are talking about, the 1,800, only about 100, 120 of them are in facilities. The rest are being managed at home. So maybe I'll start in terms first to the home management model. So the home management model seems to have removed a bit of the stress from the facilities, in that at least we are not overwhelmed with the numbers, though I must say that almost all our isolation facilities are almost reaching peak capacity. So this has really helped. So as a country, we are keeping all asymptomatic patients without comorbidities at home, while those that are symptomatic or at high risk with comorbidities will move into the facilities. This, of course, will be dynamic and changing depending on the availability of bed space and the number of cases and the severity of cases as they keep coming in. From our experiences looking at the home management model is it has helped the system in terms of numbers, but it has its own problems in that not everyone that is in the home model is able to adhere to the rules of isolation. Because one of the key aspects of the model is to ensure that people are adhering to isolation in their homes. And looking at the sheer numbers we have, we are not always able to check on everyone. So the way our model works is most of the people get a phone call to just check if they're still adhering, still at home, and to check on them, monitor their symptoms if there are any changes, so that we decide whether they need to move into facility. Then some of the people are visited randomly to just check if they are adhering and just to check on them implementing infection control measures in the home. So that's in terms of case management. In terms of lab testing, I think as a country, we are trying our level best. We've put several platforms that are able to test. I think we're using the HIV Roche platform for testing. So that has been put on board, including the conventional PCR. And now we've also added the gene experts on board. But we have had challenges with reagents from time to time. And as a country, we do still have stockouts sometimes. And our testing numbers sometimes do fall below the numbers that we want to. So that has really hindered our testing and lab capacity to some extent. We have gone around that by prioritizing testing to mostly contacts to the positives, facility testing of the patients, those especially presenting with respiratory symptoms. Then in addition, we have a cohort of those that we are following that we feel could be high risk depending on communities. But even as we do all this, our focus has been mostly now on those that present with symptoms in view of just the sheer numbers that we are having. As we mention all this, I should stress, as my colleague mentioned, we're also seeing infections in the facilities, especially of the healthcare workers. The last I checked, we're at slightly over 200 healthcare workers infected in the country. And we've put in various measures to try and reduce this. One of them is centralizing some of the facilities that are able to hold COVID patients. So not every facility is able to do that, but we have designated facilities in each province that are then handling all IPC issues and handling this. Then we have also put up testing for all our healthcare workers every 2 weeks to try and pick up those that are infected as early as possible. In terms of surveillance, some of it I've already mentioned. So our focus, of course, initially was surveillance in the communities by doing contact tracing. But we are slowly, due to resources, moving to static sites where people can come and have testing at site or testing in facilities that are designated to do the swabbing. So you get there, you're swabbed, and you come back for a result after a while. This has its own challenges in that it still promotes people moving out and mingling in facility environment and may pose a minimal risk, but we are going around that by doing this testing in open air or in tents that are well aerated and making sure we put as much IPC as we can. And talking around IPC, we are having continued IPC training in facilities, ground teams, and of course in the points of entry where we've had a significant number of cases coming in. So I think those are some of the key pillars I'll mention. I know there are more other aspects I could have talked about for country presentation, but since I know many other countries will be presenting, I think I'll leave it there for now and can take a few questions if there are some that want to ask. Thank you very much. Ezine, over to you.
Okay, thank you, Dr. Zulu. That was quite detailed and actually short. So if you have any questions for Zambia, please, you can drop in the chat box. We can move over to another country. Thank you also for touching on the issue of healthcare worker infections. So we can move over to another country. But before that, two more people joined us. So I would like to know what country they are from. I saw Lucius and Oscar Divala. Could you just introduce yourselves and tell us the country you're from before we move over to the next country, which will be Malawi? to give us an update.
Right. Okay, thank you so much. I'm Lucius from Malawi, CDC Africa volunteer. Thank you.
So Malawi, you and
Oscar Divala from Malawi too.
okay, great. So you both we have a strong team from Malawi today. So thank you for joining us today. So the next we'll go to, if you have any questions for Zambia, please you can just type in the chat box. And I'm sure Dr. Zulu is still around and he can respond while we take other presentations. So Malawi, just kindly give us an overview of what's going on in Malawi and any unique experiences you've had that other countries can benefit from. Who will be presenting for Malawi, please? Dr. Owen?
Annie, are you there?
Annie?
Anne Mwale.
Yes, I'm here.
Yes, you take us through Anne Malawi, yeah?
Yes, am I audible? My internet is a bit...
Yeah, you're a bit faint. Maybe you can speak out.
Do that.
Can you speak out louder? It's a bit faint.
Okay. Is that better?
Yes.
Yeah.
All right. Okay, thanks. So from Malawi, as of today, we have, as of yesterday, 24 hours, we have 3,738 confirmed cases, and out of these, 1,907 active, and we've recorded 103 deaths. In terms of our case management, for all our mild and moderate cases, we are managing them in their homes since the beginning of the epidemic. And so we've been employing the self-isolation for the mild and moderate cases, and only admitting those with severe symptoms requiring medical treatment. In each one of our 29 districts has an isolation center where they are able to admit severe cases that do not require any advanced treatment. But we have 11 designated treatment sites where any critical cases or very severe cases are referred to and are managed. So as of yesterday, we had about 44 of the cases in that were admitted across the country, and the rest were being managed in their homes. In terms of our testing, we currently we are testing those presenting with symptoms. Our case definition is for those presenting with symptoms who have SARI, or even any that are presenting with symptoms if they're mild and they have epidemiological link, like a contact history. And we are also testing the healthcare workers that have been exposed to any cases that they may have handled. So we switched from doing routine screening of healthcare workers in the various facilities to only testing if they've been exposed. This was also, in a way, trying to deal with the issue of healthcare workers' infection, COVID infection rates, because as of yesterday, we actually have 327 healthcare workers that have been infected. So we're just encouraging the healthcare workers to use PPEs, and we're only doing the testing if they have been exposed at the moment. For surveillance, we are, even for the contacts of our confirmed cases, we are only focusing on the ones with symptoms. And if you're a contact and you do not present with, if you're not experiencing any symptoms, you are requested to quarantine for 14 days and then discharged accordingly. We are still also testing people that are coming into the country, especially those coming from South Africa. whether they're presenting with symptoms or not, because we've seen a very high positivity rate amongst these people that are coming in from other countries. And we're also currently exploring establishing testing sites in facilities where people can go and get swabbed and then get the results from there, just to ease the pressure that is there on our healthcare workers, the rapid response teams that is going out to the community to collect swabs, which is the current to collect samples, which is the current policy that we are using. I think in brief, that is what we have for Malawi. I don't know if there's any questions or comments. Thank you.
Okay, so thank you so much, Annie, for that input for Malawi. Okay, so if you have any questions for Malawi, also drop in the chat. We'll take group questions when we are done, because apparently there are some things that are seemingly popping up in different countries. So move over to Zimbabwe now to give us updates. Zimbabwe, we have quite some people from Zimbabwe. So who is going to?
Thanks.
Okay, Howard, yeah, great, thank you.
Great. Thanks, Ezin, for the opportunity, and good afternoon to all the colleagues. So just briefly outline what we're doing in Zimbabwe, and also just point out some few challenges that we're also facing. So in terms of just describing what's happening, so in Zimbabwe to date we've had 2,817 cases, positive cases of COVID-19. With our recoveries at 604. So our recoveries have increased because we're now implementing the WHO guidelines on de-isolation of COVID-19 positive individuals. And the deaths, they're increasing. I think in the past we had about 11 additional deaths. They are now 40 in terms of deaths. And majority of these deaths are being identified post-mortem. So most of them are facility deaths, where they're being identified post-mortem in terms of testing for COVID-19. And also our health worker infections are increasing, particularly at central hospital level. You might be well aware that in Zimbabwe, we are having a job action or a strike, industrial action by some of our nurses. So at particular departments where this is happening, student nurses have had to come in and cover the gap. And some of these student nurses are the ones who are majority infected with COVID-19, primarily because of lack of experience and also absence of on-the-job training in terms of IPC. But just moving on from that, and also talking about IPC itself, the IPC pillar, where we are also supporting the government. So we are currently conducting joint IPC and case management trainings, where these trainings are being cascaded to the sub-national levels. So initially, most districts, they were not comfortable to go and train by themselves. So what we've done is we've done training of trainers from these districts, where we will train districts centrally, and then they'll go and cascade the trainings at sub-national level. So this has been quite effective because we are also including at least one person from central level just to go and support those districts so that at least they have confidence in doing even the practical sessions of IPC. So we've also roped in the environmental health department when we're doing these IPC trainings, because I think environmental health is quite central to infection prevention control as well, not only at facility level, but also in the homes, where they are also responsible for the assessments, whether the homes of COVID-19 positive cases are suitable for self-isolation. So that is what we're doing in terms of IPC. In terms of lab, we've seen that turnaround time for results at the lab is improved significantly. And this is mainly due to Africa CDC support for the laboratory pillar, where we are strengthening the lab information management system, and results are sent via emails to the facilities which should have sent the samples. And this is quite effective because now lab results are taking an average of about 2 days to get to the facilities, and the turnaround time is quite improved. And we also moved to decentralize the testing such that all the provinces have at least a site that is doing COVID-19 testing. In terms of risk communication, we're also doing communication engagement with the community. And this has been intensified because, as you know, that there's also some stigma with regards to COVID-19 at community level, particularly in communities where isolation centers have been designated. So we've gone on an engagement of the community, particularly also focusing on the business community itself, because with the business community, they were also worried about how their operations would move forward, especially when they have staff who are manning the isolation centers within their catchment areas. So we just moved in, met with the business representatives in some areas, and managed to give information, education, and communication to them so that they also know what is COVID-19, how can it be transmitted, and how can it be prevented. And that has worked as well, as we've seen that the business community is now more cooperative in terms of accommodating isolation centers within their jurisdiction. So in terms of surveillance, one big development that we've had in the past week is that we've recruited community volunteers supported by Africa CDC, who've actually gone into the community to contribute to event-based. So these are about 200 for the whole country that we've deployed. So the community volunteers were trained in surveillance, contact tracing, and also IPC. And there would also be a major link between the national and the sub-national rapid response teams, and also the community structures, just to make sure that there's that linkage in what the national, sub-national structures are doing, and also the community. Because at times when the rapid response teams are conducting their duties, the communities may not be really aware of what it's all about. But with the community volunteers, that gap is now breached, and they can be able to work in harmony with that. And also focusing on religious and cultural communication. So the community volunteers are coming in to support that, where they are also engaging the religious leaders, the cultural leaders, supporting community resilience to COVID-19, and making sure that everyone in the community is aware of the pandemic, is aware of what to do, and also is aware of where to report in case they suspect themselves or another person of being infected with COVID-19. And the community volunteers have been equipped with phones so that they can communicate directly with the Health Information Directorate as part of event-based surveillance to give alerts if they think that there are possible infections within their communities. And we've seen that this going forward might actually be quite effective in making sure that we detect every case of COVID-19 going forward. So I think briefly, without going too far, this is what we're doing in Zimbabwe. Over to you, Ezin.
Oh, sorry. Thank you very much, Howard. There's already a question for you, so you can check in the chat function. And if you have questions on any of these presentations, you can drop in the chat function. We'll circle back to them later. And then finally, we have Lesotho. We haven't heard from Lesotho in a while. So Kotso, if you're still online, could you just give us an overview? And I think we're joined by Zinkabani. Which country are you from? Could you introduce yourself just briefly before Kotso takes over?
Okay, thank you very much. My name is Zinkambani Kambame from Malawi. Okay. So I work with the Ministry of Health, yeah.
Okay, thank you very much for joining us. So Kotso, could you take us through the updates from Lesotho? It's been a while we heard from Lesotho. Kotso? He mentioned he was going to be in a meeting. Maybe I should have started with him.
Hi, I can give the updates from Lesotho since I'm here.
I forgot. Yes, thank you. Thank you. We have two people from Lesotho. Thank you very much. Can you drop your email in the chat function? Zapang Lekala? Or you can go ahead with the update.
I'll go ahead and.
Yes.
Okay, it will just be a brief update because I didn't prepare anything official. However, to date, we have 526 cases. We have about 141 recoveries. We are using the WHO guideline for the isolation to classify our people as to whether they are recovered or still active. And we have 13 deaths. For this week and the coming week, the surveillance team and the case management in IPC and laboratory are holding trainings for the districts. The rapid response teams are being trained. This week we'll train 5 districts. In the coming week, we'll train the other remaining 5 districts. So we have a little bit of a challenge with the results turnaround from the laboratory, which recently is taking about 3 weeks. Hence, it's really a huge challenge when it comes to response, because most of the time when we get the results, people have already completed the 10 days or the 14 days. Even the contacts are out of the time that they could qualify to be contacts. Hence, our contact tracing activities are really challenged because of the results. However, we have worked out a solution with the laboratory, which we believe going forward, there may be a change so that we cannot just work in vain. Otherwise, we are still coping. Some patients who have tested positive are being treated in the facilities, while some are receiving the home-based care. So that is based on the signs and symptoms. Those who are mild continue to be treated at home, while those that are moderate and severe are being managed at the healthcare facilities. I think that's all from Lesotho for now.
Thank you very much, Lesotho, for sharing with us. It's good to hear from you after a while. So are there any questions from the chat? I can't see any questions apart from Francis wants to the community volunteer training package. There's also a question for Zimbabwe from Dr. Owen from Malawi. How are you doing disinfection in work offices outside health facilities? In Malawi, we see offices, banks closing once they have a staff testing positive. Others close offices for a week. So I think not just for Zimbabwe, any country that can share experiences how they're doing disinfection when we have cases in work offices. But Zimbabwe, we can start with you since this was, I think, directed at you. If you have any, we can share with Malawi how Zimbabwe, Zambia, Lesotho, we can share with Malawi how you're doing the disinfections, because really we see offices closing once the staff is positive. So what's the protocol you use in your country?
Okay, thank you. I think currently it's almost a similar trend where if an organization detects positive cases amongst their staff, they will likely close that particular office and then commence disinfection. But it's something that we're working on. We're trying to develop guidelines for the private sector, because for the public sector, that is your facilities, your government buildings, we were actually coming up with guidelines to say, I think after a certain period, we'll then disinfect with or without the occurrence of positive cases. But for the private sector, with the private sector, usually they had their own cleaning contractors, they had their own cleaning methods. But I think going forward, we'll come up with a standard operating procedure because I think for critical institutions, sometimes such as banks, moving away from trying to inconvenience the public, I think we need to find a systematic way of how we're doing things. So currently, I think we're almost the same as Malawi. If a positive case is detected within an office, it's shut down, disinfected, and then it will open. We'll be happy to learn from other countries.
Dr. Zulu, are you still online with us? Can you share what happens in Zambia with respect to disinfections in workplaces when you have cases? Dr. Zulu? He's online, but he can't hear us.
Hello?
Oh, great.
Yes.
So did you get?
I can hear you. Can you just repeat the question?
Okay, so
not fully. I only heard the last part about disinfection.
Okay, so how are you doing disinfections in workplaces outside health facilities? For example, if you see if staff testing positive in offices or banks, they usually close for like a week. So how do you do disinfection in these places that are not healthcare facilities for Zambia?
Oh, okay, so for Zambia, what usually happens is either the public health authority goes in to disinfect, or usually we have private contractors that can be contracted to do that. Most of our disinfection will usually be based on, depending on the kind of furniture material that they use, that will determine the chemicals that they will use for the facility. But it's mostly chlorine-based disinfectants, unless where it will be damaging to the equipment. I might not be sure what they'll use if it's not, but mostly it's just a wipe down of all the surfaces and everything. And most times, in our case, we close down the facility only for 24 to 48 hours, then allow resumption of whatever work they're doing.
Okay.
Over.
Thank you. Lesotho, do you have anything to add in this?
What I have learned is that for some private institutions, they also close for some time, and they usually use the private companies to assist them with the disinfection. But for the government facilities, it is still the Ministry of Health that is assisting with the disinfection. Thank you.
Okay, thank you very much. So Dr. Owen had asked a question, I think, which some of the countries addressed when they were presenting how we're coping with healthcare worker infections, given one, people are getting infected, and two, that we are also reducing, the labor force is reducing. So I think this is a challenge that is across board. We've seen with countries. Zambia mentioned that they have, they're restricting at least focus on at least one or two facilities in each province for COVID case management, where there is proper IPC measures, people are trained, and also testing their healthcare workers every 2 weeks to catch them early. I think also Zimbabwe is also taking the approach from their presentation on also training. So that's why so as Africa CDC, we've been supporting countries with IPC training, because to build capacity, it's quite important. It's one way of approaching it, and also to